Hello, everyone. It is a pleasure to be with you in this setting, and definitely an honor and a pleasure to be on the stage with this distinguished group of women leaders. The title of this session is Fostering a Diverse Healthcare Workforce, Community-Based and Culturally Responsive Models. I would like to start first with some introductions. My name is Walter Conwell. I primarily serve as the Chief Diversity and Inclusion Officer at the Morehouse School of Medicine, also the Associate Dean for Faculty Development. I'm a practicing pulmonary, critical care, and sleep medicine physician, and I will allow each one of our panelists to introduce themselves.
Thank you, Dr. Conwell. I don't know whether you can hear me. Okay. I'm Dr. Renee McLeod-Sordjan. I love to say that I'm a jack of all trades, but I'm a family nurse practitioner, acute care nurse practitioner, and palliative nurse care practitioner, as well as being an ethicist. And I think being a clinical ethicist is really what has taught me the power of education and really being responsive to communities.
Good afternoon. Can you help me?
We can.
Buenas tardes. Good afternoon. Floribella Redondo Martinez. I'm from Arizona. I'm the co-founder and the CEO for the Arizona Community Health Workers Association. So I talk about CHW work and the community work that we all do it, and it's so vital. And we look at all the gaps and barriers, challenges that our communities have and they're facing in accessing healthcare. So we'll be having a good discussion today. Looking forward.
Good afternoon. I'm Dr. Elena Rios. I'm from Washington, D.C., but really from California. And I'm here as president of the National Hispanic Health Foundation. And just by way of background, I've spent 30 years working part-time for two organizations, our National Hispanic Medical Association and the National Hispanic Health Foundation, which was actually started with the NHMA as the NHMA Foundation. And I just left NHMA so that I could work full-time for the smaller of the two organizations and hopefully downsize a little bit as I head into retirement over the next how many years. Anyway, great to be here.
Yeah, and Dr. Rios, we know you probably will never fully retire. So let's go ahead and jump into our discussion. Creating a more diverse workforce is truly a concerted effort, and it takes sustained energy over time. But there are also barriers that have been put up to those efforts. What are some of the barriers that you have seen over the course of your career to diversifying the healthcare workforce? And we'll start first with Dr. McLeod-Sordjan.
I think we have two large problems. First of all, our mentors and our sponsors don't look like us. There is a graying of the nursing workforce, and the nursing workforce, getting older, has a lot of problems with the generational divide. And I'll say the second thing is that many of us who come from communities that have been disenfranchised or marginalized can't afford the education. We are the students that have to work. We are the students who have to take care of our parents or our grandparents. And unfortunately, if at a high school level, if at a middle school level, you don't have the right resources to be resilient in the sciences, that really limits your pathway into workforces that include medicine, nursing, other health professions, and even engineering or teaching.
One of the things that I can tell you that I have seen in our community is that majority Hispanic community, border community, not many opportunities for careers. When they're in high school, they have to be working full-time already to help support their families. When they get to college, if they get to college, then we don't have really capable counselors that can actually really work individually with those individuals to see the barriers they already have and challenges to really continue their education. It's really frustrating to see so many bright students not being able to continue a career because of the cost, because of the challenges of the funding of their family and the lack of opportunities to really think on themselves to really advance their own professional career. One of the other things that I've seen as well with our schools is that we don't have the representation to really engage and connect with those students that you need to help, to really understand where they're coming from, really understand the communities living in also, but also understanding where their parents come from, the culture that we represent. And many of the primary doctors that we have in our areas don't look like us. They don't look Hispanic. They don't speak the language. So many of our community members are really afraid of going to talk to a doctor where they have an interpreter and not being able to connect with them. So I think there's a lot of barriers and challenges. And that many of their students that should be looking and being those doctors, they come with their parents to be their interpreters a lot of time. And they see the doctor doesn't look like them. He struggles to understand the doctor as well because in languages are different. So they really get discouraged of, is this the where I want to be part of? There's a system that I want to be part of. And they don't really continue. And they have seen that they are not being taken as the next generation of health professionals. They're not taken even in consideration as being the next students in the university. They're really looking at them as second citizen status.
So I'll try to add something different. I think I've seen, we've done in-person health fairs, not health fairs, but conferences to help first-generation students in California, in Los Angeles, and in San Antonio, and at our national conferences in Washington, D.C. For 15 years or so. And I think that one of the major barriers is our own families. And it's the parents in our first-generation students that are not immigrant, but their parents are immigrants. Or their parents are maybe first generation, and they would rather see their sons and daughters not get their hopes up too high. And that everybody gets into this cycle of poverty that we can only expect so much. We have to be able to put a roof over your head, if that means renting, maybe not ever buying a house. And then you have to figure out how to have affordable lifestyle. And our families have big families. And everybody's in school or working, mean very well. And the parents want the best for their kids, but they just want their kids to be as good as they did. My father was a factory worker. My mother was a housewife in the 50s. And then she went to school and became a nurse. We actually graduated the same week. She went to a community college. And I was fortunate in high school to be able to have a job on Friday nights, my senior year, at a hospital because she was working as a nursing office secretary. And we don't see role models in our communities unless you're inside a hospital working like I was able to. And I don't want to talk personally, but I also had a 4-year high school scholarship because I won the math competition for all the regional Catholic schools. But I never would have been able to go to that school. My parents didn't have a lot of money. And for people that are even poorer, and like you said, are treated like second citizens, they don't have the inspiration, the motivation, the role models. And there's so many students that if they did make it to our conferences because they wanted to hear from other Latino and African American, we had our first conference at Drew Medical School, and we got a 5-year grant from the Office of Minority Health. And I remember these kids came, their advisors drove them from Fresno to our conference. And there was a lot of kids from Los Angeles. But these young kids, they saw Gerardo Moreno, who's now the family practice director at UCLA, and he's from the Valley. He's a farm worker family boy. And they were like totally amazed. Oh my God, he's on the admissions committee of UCLA Medical School? These were students that in college who understood that they had made it on their own, and it wasn't because of their parents. It wasn't, but they did it. And I think we have to figure out how to increase the knowledge in our own families. I was in Idaho a few months ago talking about rural states in the country and how to get more Latino and Native American students to go to medical school. It's the same problem. The parents don't encourage them, and the parents don't know that in Idaho, I had no clue, there's more money for scholarships for students if they have a good grade point average. And they will even pay for you to go to medical school in Utah because they just started a medical school in Idaho. So lack of knowledge and lack of initiative and this really, our family values are not very, we don't have the discipline, we don't have the high expectation in poor families.
Well, thank you all for sharing those reflections. And you spoke a bit about the personal, a bit about interpersonal challenges, community and cultural challenges. If we zoom out a little bit more and think about some of the legal and the policy challenges, if you can speak a bit to that. So starting first with you, Dr. Rios, maybe if you can reflect upon the impact of Proposition 209, and then perhaps we can zoom forward and think a little bit about the recent SCOTUS decision.
Yeah, California and Texas actually both in 1996 both had different decisions that were made. In Texas, it was the court system in this Fifth Circuit Court, and Texas decided we're going to allow the top 10% of all the public high schools in Texas to get into college. That's how they figured they could lay the level the playing field. In California, they didn't do that. In California, they just decided let's get rid of every single minority affairs office, what we call DEI now. Everything was closed down. All the medical schools had to change their admissions policies, and both states, which are the largest states of Hispanic students that go to all the medical schools in the country, they saw a huge decrease. Not only college, but graduate school too, law schools, medical schools. And I think that the admissions, and I was part of the minority admissions at UCLA Medical School when I was a fellow. And this was before 96, this was in 90, I don't even know, 90 to 92 I was a fellow, general internal medicine fellow. And I remember the Minority Affairs Committee, not Minority Affairs, but Minority Admissions Committee, was very important to being able to discuss, and to understand the complexities of the background of our poor students that were trying to get into medical school. And so they abolished those committees, and there had to be one admissions committee at all the different medical schools. And so there you go, more barriers. But I think the positive thing that happened was that there was a recognition that we had to get rid of the word race and not look at minority, variables, but let's talk about a different way of approaching how to talk to students to understand their background. And that's what's going to happen now, that there will have to be a re-education, and the AAMC calls it holistic admissions, and a re-education of not only the faculty on admissions committees, but the students who apply on how to express yourself and tell your story so that you can be unique and be of value added to the school who wants to invest in students that are going to be, empathetic physicians of the future and empathetic for the community that they're going to serve. And so if you're Latino students, it's expected that you will help the Latino community. So looking at how your experiences in your family and et cetera will be helpful to the admissions committee, they had to start thinking about how to ask questions that were more targeted to what a good physician would be for your community or for our school to be proud of, and besides grades and numbers. And I'll just say that probably the MCAT scores and everything else, they probably did have to look at higher level students. So that was the trade-off of not being able to have what we would call an affirmative action approach, get rid of the affirmative action, and everybody had to be more qualified than you were in the classes before, and which means more competitive. So for our students, it's even more, as the years have gone by, it's become even more competitive with students having to do research or do more, have more experience, learn about programs, summer programs, all those kinds of things that evolved from those experiences. So we have those now, but I don't know how many of the states that weren't California or Texas have that kind of experience. And that's going to be the next generation of medical school challenge.
It's early to recover. In some schools within California still haven't recovered their diversity. Other schools like UC Davis actually were able to bounce back and now have greater diversity numbers than before. So it definitely became a school-specific programmatic effort. But as we zoom forward, perhaps we can talk a bit about SCOTUS and the recent Supreme Court decision and the impact that that has had on, or we think it will have on workforce diversity. And I will allow either of you to speak to it.
So I want to echo something that Dr. Rios said in answering that. We know that it's going to be devastating. I think nursing has followed the lead of medicine. We've known for years that a GRE did not determine whether a nurse was going to be resilient. I think as we look at policies to override some of the things that the SCOTUS decision has seen, we have to realize as educators, it is in our power how we do the admissions process. I always like to say that with healthcare, going through your insurance is the most difficult thing in the world. Well, for a 21 or 22-year-old who has never had a family member who's a physician or a nurse, or as you talked about, going against your parents or your grandparents, the education system can be daunting. To learn how to be empathetic, especially in a language that is not your native language, can be daunting. So it is up to us as educators who are in medical schools, who are in nursing schools, to change those admission processes and start with pathways. We've had affirmative action for years, and affirmative action was turned into quota systems. And we know that we who are Black and brown and indigenous had to be better then. So it was never a question of were we going to be at the top tier. As you said, Dr. Rios, we were. We were the top 1% of our high school classes. We were the top 1% of our college classes. We're the top 5% of medical schools, and yet Black and brown men have the hardest times getting out of medical school. So I think we have to look at the SCOTUS decision, and again, as you said, in California, change the narrative to how are we going to admit and how are we going to help students prepare for financial aid, scholarships, admissions, having those holistic interviews, and we can do that.
I just want to add that as a community member, I think, and I've seen the challenges of our students trying to get into medical school. My son being one of them. I was talking to Dr. Helen about that right now. But it is important to have programs that we prepare our students. We get them early enough to really provide them with the tools that they need to be prepared. And even when they're 100% prepared, there's still so many challenges. Just because when the universities pick the percentage that they're looking for, they disregard the hundreds that don't appeal to them as successful students. Those are the things that we need to really look at. How do we prepare now that the universities do not have to justify how they're going to be picking their students? I think that was difficult before. Now for our students, it's going to be even more difficult. But we can do it. We can prepare them, but we need to look at programs like Dr. Elena's program that they prepare. How do we replicate those throughout the states? Because not every single state might have access to your services. How do we get those funding? How do we get those services? How do we really advocate for our students to be able to get into those medical programs? They're out there. They're really there, but they're not getting our students from our communities. They're getting other students. they're really more appealing, like I say.
Yeah, I just want to add one thing about the Supreme Court decision. We did a webinar. We have a webinar on our website on nhhfx.org of Dean of, I believe it's Georgetown Law School, and she comes from a public health background. She's actually a PhD in public health, and then went to law school, and she became a dean. So her webinar was about how this is really about health equity and health justice, not to have students going into the health professions. And we specifically asked her to relate to public health, because we're looking at how do we get more diversity within public health given the COVID pandemic. We actually have a grant to do this, to look at how to recruit more minority students. And she said, and I hadn't realized this, the Supreme Court decision was about the institutions not using race in their decision-making, right, for admissions. But Chief Justice Roberts said in his opinion that we can still consider race and as a student's experience. So it's what we really need to do is turn everything upside down and start focusing on students, on how to write their essays, how to do their interviews, and to be able to show the importance of their experiences and their stories to the profession of medicine and nursing, dentistry and pharmacy. And that it really is up to us and the alumni of these schools to understand that we can make a difference. We can, and you're right, we have to have more. So we've been doing scholarships for 20 years. And I think that it's just it's encouraging, but it's not enough because it's so expensive. But anyway, I don't want to. But just to say that the SCOTUS decision was not a closed door. No.
Chief Justice Roberts did pin the majority decision for a reason, because the impact of racism on a student or applicant's experience can still and should be considered. Mm-hmm. Now, to your point, many of the programmatic efforts that would help to support those applicants in understanding how to craft their experience within their applications would fall, those programs would fall under the umbrella of diversity, equity, and inclusion programs at many of our institutions and organizations. But those DEI programs are also under assault right now, right? At the state level, at the local level. So perhaps you can tell us a bit about how you have seen these anti-DEI efforts play out, and what are some strategies that our participants, our listeners could consider as they attempt to navigate these issues?
Well, I was just trying to figure out, thinking out of the box, which I try to do with policy, right? What's happening in our country in healthcare is the realization that medicine should be more public health oriented. The social determinants of health, I think, is the answer. The social determinants of health mean that we talk to people about the barriers that they grew up with housing or transportation or childcare or having big families, what have you, and use that as the way to talk about the importance of the future doctor who can be a community asset. I'll just say, talk about it in terms of asset, not in terms of, well, you're just a lowly Mexican American, or that's just going to be in go work in clinics and not help the research of our university, which is to be the best to cure cancer. You know what I mean? We're treated like second citizens. But I think that the having the asset, having the language, having the cultural understanding of patients, if that was the asset for doctors and nurses, from the admissions perspective, we would be 100% of the population in the medical schools, not the few that get in. And so there has to be a rearrangement of what is the best criteria for admissions and recruitment. And it's not DEI. It's not the words diversity or equity, or it's about, our communities. The healthcare of the community, I think, is what we're going to move toward in the future when we talk about social determinants of health. And the other big thing that's happened, and this is CDC and the Office of Minority Health, is the vulnerability indexes, where policies and programs are being directed to the poorest communities. We saw it in the pandemic. There was somebody that spoke about NIH earlier, about somebody, I actually met him, he's from Morehouse, a very, very important gentleman, but he was telling me, we were talking about it afterwards, the funding was redirected to those states in the country that had the worst mortality rates for the pandemic. NIH never did that before. And NIH also gave grants to start coalitions and community connections. You know, the vaccines had to be delivered to the community, and they had to figure out who was going to do that. Well, the trusted messengers were the community-based organizations. So the concept of really looking at health professions admissions as people that are going to take care of communities, not just people out there for the medical schools, you know, to be proud of. So anyway, I think that's what's going to have to change.
One of the things that I can talk about the community health workforce, which are really addressing the social determinants of health community. And we're working with providers, we're working with health systems in place. However, I believe that there's a lot to be done in really integrating the community health worker into the team. Just because we're the tokens that now, because community health workers is a buzzword right now. Everybody wants to work with community health workers. They really don't see the vital role that we play. Identifying, referring, really connecting, but also providing the follow-up with the individuals in their own setting. We meet them where they're at. But we also bring them to the doors of the clinics or health systems. We are preventing many emergency trips. At the same time, I think the doctors do not connect with the community health worker because they see them as a really low individual and not at the professional level that they are. So when we're talking about really bringing in and enhancing the healthcare workforce and really understanding the social determinants of health or community settings, one of my friends, Dr. Lee Rosenthal in University in Texas, they have a program where dental students have to, when they come in, they have to follow community health workers for 2 weeks. They have to go with them to the community. They need to connect with the community, ask questions that really understand where they're at, how they live, the various challenges that they're really are living every single day, to really understand how they're going to be able to serve them the best. And unless we really get doctors to really connect with patients, clients, we're not going to be able to get there. One of the things that I can tell you is that when you see me, you see a brown woman, and you see a minority woman. The majority of community health workers are a minority community and women of color. However, we were the first to respond with COVID at community level. The community health workers were the first to go out and embrace and really understand and try to make sure that everybody was safe and had what they needed, the medications they needed, connect them with the providers through phone calls, whatever it was, if the individual didn't know how. So we made a lot of progress on that. However, we weren't integrated in the public health system infrastructure. However, we are not taken in consideration. We're just there as a name. But when they develop policies around healthcare that include community health workers, we're not, and right there, putting our voice into the next level of what we're going to do. So we're not taken into consideration, really. We're just part of. So unless we really come together as a health system workforce, we're not going to be making much progress. We all have a role to play. And if we all play a role, we can all work at the top of our scope. If we know where we belong, if we know how we can continue working together and really advance our work that we do in the health to really advance the health outcomes of our communities that we're serving.
You know, I'm glad that you mentioned that, because when we start looking at our workforce and where the black and brown are, they're said to be at lower levels, whether it's the community health worker, the public health worker, the certified nurse assistant. And I think what we have to remember is that we need to, as you said, teach interprofessionally, but we also need to remember that there's a such thing as a social determinants of education and how we create pathways for people to move through. That's how I started with saying to you that I consider myself a jack of all trades, because the first thing that I ever did in life was be a respiratory therapist. Who knew what that was? But as you said, Dr. Rios, that got me into a hospital. And from there I could see, wow, maybe I want to be a physician. Maybe I want to be a physician assistant. Maybe I want to be a hospital administrator. But along each way, there was a pathway of education that led me to the next step, all the way through to doctoral education. We have not really been good at addressing social determinants of education to recognize that people can become physicians not along the traditional path. They can become nurses not along the traditional path. They can have a living wage as a community health worker because that is so vital. So we need to make sure that people have living wages, but that we're so interprofessional in the way that we educate that you are not repeating a degree, you are leading to a pathway to a different degree.
So, want to be cognizant of the time that we have, and would love to open up to the audience for questions. If each of you, though, could briefly give some closing thoughts and perhaps also share a little bit about what your respective organizations are doing to diversify the healthcare workforce.
Where would you like us to start?
If you can start, please.
So I am proud to say that I'm in the Morehouse School of Medicine, and we are planning on creating pathways for nursing that include midwifery and bringing people that previously didn't think about nursing to come in to be midwives, to go out into the rural areas because there are just not enough of us in this space. Not enough physicians, not enough psychiatrists, not enough OBGYNs. So what we are doing is thinking outside of the box. Competency-based education, pass-fail education. Because why should everything rest on the numeric number that you have that is 100? But rather that you're competent, that you know how to get into the health justice space, social determinants of education, social determinants of health, and make a difference. And what do you call a doctor who is at the bottom of their class? A doctor.
Well, with the Arizona Community Health Workers Association, one of the things that we're doing is really connecting with the health systems, our Medicaid at the state level, with our health plans, and ensuring that the community health worker that are certified can actually get reimbursed, but also be recognized and respected as a professional. One of the things that we are continuing the advocacy, because even though we've been doing this for many, many years, many health systems or providers do not understand the role that we play, the vital role that we play, and they still don't respect the CHWs as a colleague, or they see them really as, like you say, the lower level of employees, and we're not really getting that recognition for the work that we're doing. So that is really moving policy and advocating at the state level, really connecting the providers that don't know about CHW workforce too, so they can truly understand what we're doing, and really educating them.
So I'm going to say a couple things. One is we're working at the leadership levels. I recently left NHMA, so we're trying to separate the two organizations financially, but also, our vision. And our vision at NHMA, just like any other association of members, is to take care of your members and have a conference and have chapters. But NHMA, by definition, is a medical association. So 20 years ago when we started our scholarship, we said, no, we want to be able to help those students in the health careers that will help the Hispanic community, whether they're medical students, dental students, nursing students. We even started a National Hispanic Pharmacists Association because there wasn't one, and the PAs, and as well as medical students. So we see ourselves as an umbrella to help interdisciplinary professionals come together. This has never been done, but we're going to try to do this. And our new mission is to transform the healthcare system with leadership, research, and education to improve not the health of Hispanics, but Hispanic health equity. And that it's a community approach. And our leadership, we have a leadership fellowship program. We've had the leadership fellowship program for 30 years under NHMA. Under NHHF, we got funded from California to do a California Leadership Fellowship. And one of the focused efforts in California is going to be how to increase the number of Latino doctors. There's a proposition on the ballot right now called Prop 35. It's going to give $17 million for GME in California. It's going to be a game changer if it passes. Hopefully, California Medical Association, the California Primary Care Association, the clinics in the state, to have clinic training for more residents and doctors, not just the hospitals. So leadership development. The other thing we've done is nominate more of our networks, whether they're Hispanic or not, but to advisory committees at HHS and in California with the governor's appointments. And the other thing we're doing, not the leadership, but on the research side, is getting into the clinical diversity space, clinical trial diversity space, and developing a database of principal investigators around the country that are Hispanic, and trying to figure out, we're going to work with the AAMC on connecting to researchers in the medical schools that are junior faculty or even residents or medical students interested in research. And again, they don't have to be Hispanic, but we have to force the issue of how to find more people like-minded to be mentored and coached in their careers, and looking at career focus for the long haul, because this country is going to have 1 out of 3 Americans are going to be Hispanic. Well, we've got to have more documentation, more language, more role models, more faculty, as well as more community doctors doing clinical trials. So we really want to focus on that, the leadership research, and our education is a scholarship program. And advocacy will always do. I will always do advocacy in Washington, but I have to say, I think what we really need is to work with the HBCUs more. And I've worked with, I know David, Charles Drew University. We were fellows. He was a fellow right above me. And I have to say that I think that the model that you already have, we're never gonna get it in the Hispanic. We're gonna have a different model. It's gonna be community approach, but not the medical schools. We don't have Hispanic medical schools like the HBCUs.
Well, there are some exciting developments with some of the Puerto Rican medical schools opening campuses on the mainland as well.
Oh, yeah, I know.
Yeah.
Ponce did in St. Louis.
St. Louis, and their plans
For New York.
in New York as well. Yeah.
So. Well, I mean, I just think that HHS tried to develop the Hispanic Serving Health Profession Schools. I worked for that for maybe 3 or 4 years. The Hispanic Serving Health Profession Schools was supposed to be a mirror image of the minority health profession schools and the black schools. But what happened was the definition was mainstream medical schools that had 9% Hispanic students. The money was given to the medical schools, but how do you know that it ever went to the Hispanic students? Right. And maybe I don't think it's that difficult for a HBCU school to say we're helping our community, because that's the whole point, right? I mean, the mainstream schools, I think I can see the few Puerto Rican schools coming to the mainland, but it's not enough when you got 60 million people that are Hispanic. Right. We really need the schools that are here to change, and it would be nice if we had more leadership that was Hispanic in the medical schools that are here. It takes all kinds of solutions.
Yes. Well, I want to thank you all for your insights, your guidance, and would love, I know we are over time a little bit, but maybe we can take a couple of questions, please.
Thank you so much for this panel. I have a question. So you mentioned having assistance with helping with the personal statements and things like that with applications for med school. So prior to getting that, you have to get the MCAT score. That has been the one barrier that we have seen with kids trying to get into med school, is that MCAT. If that MCAT score is not hit, they won't even consider your application. And we've experienced that with our own child who's been going through that same process. So what is being done at that point? Because the resources are, that we found is that those with the most money get the better resources. And she's let me know that she needs about $5,000 to get resources to help the study for the MCAT. So what can we do? What's out there to help?
I can briefly speak to it. You're absolutely right. The MCAT is a barrier. It's a gatekeeper for so many of our learners, much like many of the other standardized tests are, from the LSAT to the GRE, etc. Now, there are some programs, even as we think about holistic admissions and other ways to look at our applicants for medical school, as long as the MCAT is there, we still need to wrestle with that. And there are some programs, particularly post-bac programs, that are free for students or that have a significantly reduced cost, or where students can apply for scholarships. And many of those programs offer MCAT assistance. So identifying and really having, ideally, a central clearinghouse such that students don't have to spend the extra time, the energy, the money to try to find which programs might be best for them, which programs might provide the resources that they need. Those are some of the things that we could do collectively to lower the barrier for our learners.
And I think the other thing is that if we're looking at students when they're in college to fix an MCAT, we're already too late. So the programs that we really do for STEM in middle school, in high school, particularly in communities where the zip code is not getting the resources for education, that's where money has to pour. That's where the money has to pour. You're too late.
Well, and there's always, as long as you are able to find the sponsor, able to find the support, there is always an opportunity. So that's where the resilience comes in. And then also making sure that you are doing what you can to identify any internal barriers that may be there. And what I mean by that, what we have found at the Morehouse School of Medicine, so we typically and historically have taken students who are on the left side of the bell curve. MCAT scores down as low as 488, 489, etc. And we have shown that over time, by the time they take step 1, step 2, they score as well, if not better than the majority. But what we also found, and we actually have published on this, we call it shifting the curve, and we've done it, decade after decade after decade. And it was always a question mark of exactly how do we do it. So the milieu, the Morehouse sort of a model. But we found that during the pandemic, many of those students fell off a cliff. So some of the students, the same demographics of students that historically had done very well during the pandemic, they failed step 1. Yeah. We referred the vast majority of those students on for disability for learning difference testing, and almost none of the students that we referred came back without some diagnosis. A good proportion of them had undiagnosed learning disabilities or mental health challenges, and the rates were far greater than the published rates of learning disabilities in medical students. So we're actually working to publish this right now as well. We think that historically we actually have taken students who have undiagnosed learning disabilities, but because we had the in-person environment, we had this milieu, we were able to support them through it. But putting them in the virtual environment, it kind of uncovered these issues. So the point there being is, if there are students out there who always struggle with standardized tests, with the SAT, the ACT, they're struggling with the MCAT, etc., it may be that there's something else going on. And instead of just kind of putting their head down and forcing themselves through yet another MCAT administration, getting testing for learning difference might be important, because if they can get accommodations, that can completely change the trajectory of their life. Yes.
So, what is your perspective on retention once you actually get people into the professional pathway, right? Because what we're talking about is very important. one of the conversation elements that sometimes I don't really hear mentioned as much is if you are successful with getting people through the gauntlet, how do you
Get them
allow
on
them
that side.
the supports to keep them so that they actually make it to the actual workforce?
So I'm going to be a heretic here and say something that, and don't endorse this political point of view. But, from the nursing programs that I built, it was no student left behind. It's the faculty partnering to say, we believe in you and we're going to work with you. And we call that remediation and recitation. You do not allow a student to go through 6 months and fall off a cliff. There are frequent connections and frequent pre-tests, mini-tests, all of those things, accommodation, teaching in a different way. We're sitting having a collective conversation. Think about how we were educated and whether we ever saw 4 learned people in front of us in a class. So we do a lot of team teaching because I might not be able to get to you, but they can, right? So it causes us to think about how we teach, who we teach, and how authentic we really are. And so one of the things in every place that I've ever been in, I'm not here as your educator to fail you. You are going to try to fail yourself, and I will not let you. And if we start there,
That's true.
every single
Yeah.
student can get through because we have that obligation. We brought them in because they have something valuable to health professions. I want them to take care of me in the future. I'm getting too old to do this.
I think we might just drop the mic on that one. So if you can join me in thanking our panelists one last time.